Dear Chair, dear audience, welcome to my presentation at the one-year progress report. The title of my thesis is The Role of Prevention and Early Intervention in Autoinflammatory and Venereal Diseases. My name is István Szondy. I'm a medical doctor and a full-time PhD student at the dermatology clinic. First, let me share my vision with you, which is fewer complications in autoinflammatory and venereal diseases. To realize this vision, my mission is to introduce prevention and early intervention in the clinical practice to reduce the rate of complications. For this, I have two projects right now in the field of venerology, and in the first one, which is investigating the efficacy and safety of doxycycline in preventing sexually transmitted diseases, I am conducting a systematic reviewed meta-analysis with the help of my team. Sexually transmitted infections pose a global threat as there are more than 1 million new cases of chlamydia, gonorrhea, and syphilis diagnosed every day worldwide. These infections are curable, but they have to be caught early, which can be challenging due to reluctance to seek help at asymptomatic infections. Non-treated patients infect others, while the initially curable disease causes irreversible damages to the body. To prevent this, a novel approach is to administer doxycycline as a prophylaxis. Chlamydia traumatis and Treponema pallidum are generally sensitive to this agent, while Neisseria gonorrhoeae shows moderate to low susceptibility. In a low dose, it is considered to be safe, so the question remains whether it is effective enough to prevent STIs, which is our goal to assess. For this, we use the PICO framework. The population is sexually active adults, and the intervention is either doxycycline pre-exposure or doxycycline post-exposure prophylaxis, and we compare it to no prophylaxis. Our primary endpoint is the effectiveness, and we have 3 additional secondary outcomes. We hypothesize that the use of doxypep and PrEP can reduce the number of new cases of STIs, with which we could reduce the burden of STIs on high-risk populations. On the first forest plot, you can see the total number of visits and the number of visits with an STI event in the doxy prophylaxis and in the control arms. We included a total of 6 randomized control trials, 4 of which assessed post-exposure prophylaxis and 2 assessed pre-exposure prophylaxis. 5 of these 6 studies enrolled men who have sex with men and transgender women, and only one study, the study by Stewart et al., included cisgender women with male partners. The heterogeneity was substantial at 73% due to the different degree of risk reduction. Overall, the relative risk was 0.44, translating to a clinically relevant 56% decrease in the risk of acquiring an STI with the use of prophylaxis. If we included only the post-exposure studies, which you can see on the upper part of the figure, the risk ratio stayed around the same. However, we did not have enough studies to conduct a separate meta-analysis on doxyprep. And here on the next forest plot, you can see the results for doxypep broken down by infections, including only MSM and transgender women. As you can see, all the results were significant, including the one for gonorrhea, which means that this doxypep could prevent even gonorrhea in regions with low prevalence of tetracycline-resistant Neisseria gonorrhoeae. Notably, there was a remarkable 77% reduction in the risk of acquiring syphilis with the use of doxypep, which deserves particular attention due to the serious complications of this disease. As for the secondary outcomes, there were no serious adverse events reported across the studies, and only one study reported poor adherence to prophylaxis, which led for the prophylaxis to be ineffective. The major concern around this topic is the emergence of new antimicrobial resistance as a result of extensive antibiotic use, yet none of the studies have been able to provide evidence on this. We included only RCTs in our meta-analysis, and this is the first meta-analysis on this topic. However, there is only a limited number of studies on this topic, and 2 of 6 studies had not yet been published at the time of the assessment. Only conference abstracts were available. Furthermore, we lacked enough studies to conduct a separate quantitative analysis on doxyprep. To summarize, we provided evidence that doxypep is effective in preventing syphilis and chlamydia infections in high-risk MSM populations with potential effectiveness against gonorrhea, likely influenced by local resistance conditions. The thorough assessment of the resistance issue is crucial, as the emergence of new tetracycline resistance due to prophylactic use will determine its long-term applicability. Based on our results, we advocate for the use of doxypep in high-risk MSM populations with careful patient selection. However, additional studies should evaluate the effectiveness of doxypep and PrEP in cisgender women and in males with female partners to ensure that these findings are applicable to a broader demographic. I am happy to share with you that our manuscript has got accepted this summer by the International Journal of Infectious Disease, and now it's already published online. And now let me present you my second project, which evaluates the potential role of meningococcal vaccines in preventing gonorrhea. The growing number of multi-resistant strains of Neisseria gonorrhea is an emerging problem, and despite the attempts, there's still no available vaccination. On the other hand, we have several effective and safe vaccines to prevent meningococcal disease. Neisseria meningitidis, a bacterium from the same genus, has very similar outer membrane components, which could be the basis of cross-protection offered by these vaccines. Based on these, our goal is to determine the effectiveness of OMV-based vaccines in preventing gonorrhea. For this, the population of interest is anybody eligible to receive meningococcal vaccines, and we compare OMV vaccines to no OMV vaccines, which could be other non-OMV meningococcal vaccines or no vaccine at all. The outcome is the incidence of gonococcal infection, and we hypothesize that OMV-based vaccines indeed provide cross-protection against Neisseria gonorrhoeae. Here on the first plot, you can see these results for this vaccine effectiveness outcome. We compared the incidence of gonorrhea among vaccinated individuals to that in unvaccinated controls, and we included a total of 7 studies, 6 of which were retrospective studies, case controls, and cohort studies, with only one of them being an RCT. The heterogeneity was moderated at 55%, likely due to variations in study designs and population characteristics. Overall, the odds ratio was 0.62, which translates to a clinically relevant 38% vaccine effectiveness, which was also mathematically significant. The included studies investigated large cohorts of patients, and the similar follow-up times contribute to the reliability of our pooled results. However, to date, there's only one RCT available, and varying study designs and population characteristics limit the generalizability of our results. To conclude, OMV-based meningococcal vaccines offer moderate and probably short-lasting protection against gonorrhea and could be recommended for high-risk individuals. Additionally, OMV vaccines should be preferred over non-OMV vaccines when it comes to the vaccination of sexually active adults. However, additional RCTs with longer follow-up times are necessary to establish causality, to determine the duration of protection, and to find optimal timing for a potential booster dose to extend this protection. I am almost finished with the manuscript, and we are discussing it with my supervisors in the upcoming weeks. And to summarize, I have 2 projects right now. The first one got accepted and published this summer, and we are planning to submit the second one in the early weeks of October, along with discussing the third one. And finally, I want to thank you for your kind attention with a quote from John Steinbeck. "It is in the nature of man to rise to greatness, if greatness is expected of him." Thank you for your attention.
In the second project, basically you have 6 studies, probably that you use.
7 in the meta-analysis, yes.
Almost all of them show the same tendency. So I would assume that even individual studies show the same conclusion. Yes. So when you run the meta-analysis and then when you will publish this somehow, what will be your conclusion? That, like, what is it that you add to the independent papers? Can you do like a stratified subgroup analysis to identify one population in which this is really, really important? Or is there anything else that you can add to make it even cooler?
No, actually we don't plan to do subgroup analysis. However, there was only one RCT, the Molina RCT, and as you can see, that one wasn't actually significant, the second from the bottom, and the others were retrospective studies, case controls and cohort studies, and 1 or 2 independent retrospective studies, in my opinion, is not feasible to suggest they are only able to suggest something, but pooling them together, I think, and having a statistically significant result, I think that adds to the individual studies. And also the studies investigated different patient populations, used different controls. So I think the pooled results, these significant pooled results has value.
Is it possible that in the RCT that there was no significant difference because of the short follow-up time? Because that's almost the shortest from almost all of them.
Yes, it could be possible, but actually they also found a decrease in the incidence of gonorrhea, so the odds ratio is 0.73. I think maybe the relatively short follow-up time, and the other thing is the patient number. You can't see the patient numbers in all of the studies, but most of the studies investigated whole populations, so like 15,000 patients and so on. So I think if Molina would have enrolled more patients than 540, then I think we would have seen statistically significant result. So the tendency is there, only the significance is not.
Congrats.
It was a very nice presentation. I have a question for your first topic. In the everyday practice, which group do you advise this kind of prevention? Or I can't really understand the concept because if you have some unprotected sexual intercourse with foreign people, you have a great risk to have some sexually transmitted disease, and this kind of prophylaxis can save you from the listed infections which you mentioned, but you also can have HIV infection or whatever, and doxycycline will definitely not defend you against that. So
yes, thank you for your question. So now this intervention is only recommended for a very small proportion of the whole population, these high-risk MSM individuals. So this high risk, it is defined in different ways, but it includes either living with AIDS virus, so already having the virus, or taking HIV PrEP. So every day an agent, antiviral agent to prevent HIV. And in the included studies, every participant were either on HIV PrEP or on HIV medication. So we wouldn't recommend this intervention without having a HIV PrEP intervention also.
Okay, thank you.